We have our next session online by Dr. Tejinder Singh, Competence-Driven Assessments for Quality Education. For this session, we have our chairperson, Dr. Jyoti Chopra. She is the controller of examinations of KGMU. With her undergraduation and post-graduation from GSVM Medical College, Kanpur, she has a total teaching experience of more than 27 years with a keen interest on medical education and has contributed extensively towards the integrated curriculum program. Thank you, ma'am. Ma'am, I request you to kindly come forward and introduce our speaker.
To introduce Dr. Tejinder Singh, who is a speaker for next talk, which is on competence-driven assessment for quality education. Dr. Tejinder Singh is a pediatrician. He is a fellow of Indian Academy of Pediatrics. He is member of National Academy of Medical Sciences and is working with CMC Ludhiana since 1986. Sir has joined as head of pediatrics at CMC Ludhiana in 2006. He has been awarded fellowship by Swedish International Developmental Agency, Foundation for Advancement of International Medical Education and Research, Indian Academy of Pediatrics, and International Medical Sciences Academy. He has been member of various committees formed by national level by MCI and Ministry of Health and Family Welfare to formulate the curriculum of UG and PG education in pediatrics. He has also been a member of a core group to develop curriculum for faculty development in India. He has written 2 books, 30 chapters, and 200 publications to his credit. And I want to add that 2 books on medical education are really a bestseller and have to book on our bookshelf for medical education. Dr. Tejinder Singh is a founding course director of CMC Ludhiana Famer Regional Institute and MCI Regional Center for Faculty Development Program at Ludhiana. So with these words, I want to welcome Professor Tejinder Singh. And I would like to add again that he is a gem of a person, always ready to help you out, always responding to your queries. So welcome, sir, for this session. We are eagerly waiting for your talk. Thank you.
I couldn't make it. But I do hope that we will have a meaningful discussion and deliberation, and that will go a long way in improving the quality of medical education, especially when we have the new curriculum in place and we are already looking at the first batch of students being out and being ready to practice. The new competency-based curriculum, which India introduced in 2019 with the intent to produce an Indian medical graduate, actually started with the 5 roles, which included clinician, leader, communicator, lifelong learner, and professional. And I believe that recently they added 2 more roles to that, which include critical thinking and researcher. So now we are looking at an Indian medical graduate who will be competent to perform these 7 rules in day-to-day practice to improve the health status of the population and be responsive to the health needs of the society. Now, before we proceed further, I would like to have a look at what does competency-based education mean. In fact, interestingly, this word based actually can create a lot of confusion, because once you say based, then it can mean anything. Everybody can interpret in a different way. So to make sure that we are all on the same page and we are all talking of the same thing, I would like to take you through the definition given by Frank and Associates as part of international competency-based collaborators. And this says that CBME is an outcome-based approach to the design, implementation, student assessment, and evaluation of medical education programs using an organizing framework of competencies. I'm sure you have noticed that the keyword here is organizing framework of competencies. So in other words, for everything, whether it is design of the program, implementation of the program, or more importantly, student assessment, the unit of assessment has to be the competency. And if we are not doing that, then probably we are falling short somewhere in assessing the Indian medical graduates. Another interesting thing which I came across was a quote from 1976, almost 50 years ago, when Harrison Keller said that the effort in competency-based education should not lie in the design of instructional material, but in the design of appropriate assessments. And I hope you will agree with me that this is something where we have not really gone on as advocated. Because our major focus has been on the creation of timetables and creation of other learning resources and materials, rather than on designing appropriate assessments. And until and unless we have an assessment system which assesses competencies acquired by the student, it will be very difficult to say that we are actually imparting quality competency-based medical education. So in this perspective, let's look at what is assessment. Now, again, various definitions and various conceptualizations of assessment are possible. What Watson says is that assessment is the systematic collection, review, and use of information about educational programs to improve student learning. And if you read this part of the definition, then what becomes clear is that the purpose of assessment is actually to improve student learning and not really deciding pass or fail. No, that's one thing which we will need to think about and will need to change. And secondly, the assessment is to focus on what the students know, what they are able to do, and what values they have when they graduate. So it's not just knowledge and skills. What they know and what they are able to do is obviously there, but the values, the attitudes are as important because they are all part of the competency-based medical education. It's interesting to look at evolution of assessment. In fact, if we were to look at how assessment of competence has evolved over a period of years, then it is possible to actually think about three different periods or phases. The first one, where we thought that competence is generic, fixed, and transferable across content, was what is called measurement era. Because everything in assessment was actually measurable. MCQs, essay questions, whatever you do, we only were concerned with the mark, how much the student has supported. And we believe that if a student can do task A, he will be equally good in performing task B and task C, because competence was thought to be transferable. However, around 70s and 80s, early 80s, we started thinking differently in terms of a decision making. And that is when we realized that actually competence is specific. Flying an aeroplane is very different from driving a car. And it is non-transferable. If you are able to make one food, it does not mean that you will be able to make another food also equally well. And third is what is known as programmatic assessment era, which actually came around 2000s. And the basis here was that competence is dynamic, incremental, and contextual. And the keyword here, I would say, is contextual. Somebody might be very competent, highly competent, for example, in a primary health center. But what happens when you place the same person in a tertiary care hospital? Or vice versa? somebody who is very competent in giving extracorporeal membrane oxygenation in a referral hospital, but you put him in a primary health center, what would be the competence? So this context makes a lot of difference. Competence is not an inborn trait. It's not an inborn characteristic. It is something which you acquire. It is something which keeps on increasing with experience and with learning. And it is something which is related to context. Now, with this background, what we know is that, and this is important, competence does not reside in the individual. So it's wrong to say that person A is competent or B is incompetent. Rather, competence resides in the way an individual interacts with the context. And I gave you the example of primary health center and a referral hospital. And competence is not something which is, outwardly visible. It's not a halo around your head to say that you are competent. Rather, it has to be inferred only from performance. So what the student does tells us about how competent he is. Against this, what we seem to believe is slightly different. So what we believe is that medical roles can be broken down into individual elements of knowledge, skill, and attitude, and these can be rejoined to create a competency. Now, I think that this is fallacious. In fact, if the student was taught in isolated way about knowledge, skills, and attitudes, and we believe that he will be able to rejoin them to form a competency, then probably we are mistaken somewhere. If that was so, actually speaking, there was no need for competency-based medical education. CPME came only because the students were not able to integrate the knowledge, skills, and attitudes. And if we keep them assessing them separately, then we are not doing justice to the process of competency-based education. We also believe that performance can be tested only like a race, precise 2.001 second, and not like a gymnastic. So that objectivity mindset still prevails. We believe anything which is not objectively measurable is not important. So whether it is professionalism or it is communication or lifelong learning or leadership, because they can't be objectively measured, so they are not important. Sometimes we even deny their presence. Another important factor which actually comes is that in our emphasis and enthusiasm to really equip the students with skills, we have actually gone too far on the performance part. And we ignored the role of knowledge. Earlier, we used to classify students as bookworms, who only read and who don't, or who cannot perform practical procedures. Now it has become other way around. Now we try to produce students who would be able to do something, but may or may not be aware of the theoretical considerations behind that process or procedure or operation or whatever. Now, there are people who would believe that if you use performance-based assessments, then it would promote learning of clinical skills. Fine, fair enough. But there are also a lot of evidences available to say that observed performance is not closer to real performance. So in other words, what a student demonstrates in the examination hall doesn't get replicated in real life practice. And I strongly believe that diagnostic reasoning is the first step of competence. The first step to become competent is to make a correct diagnosis. So competency is making a correct diagnosis, not being able to discuss and describe something. And let me remind you that diagnostic reasoning actually depends heavily on a very sound knowledge base. If we focus only on behavior, then you are only looking at the distal outcome. You're not really looking at what the student is doing now. And there are studies to show that OSCE scores actually do not align with diagnostic reasoning skills. A student may be able to perform a procedure, but if your diagnosis is not right, then the utility of that skill becomes doubtful. Another study which I came across, it actually gave an MCQ test to the students on commonly assessed procedures. And that's interesting that the students passed all the skills, but the pass rate on MCQ test related to knowledge on those skills was only 39%. So in other words, there was a mismatch between knowledge and skills. And we also know that when we have a situation like this, then students, they resort to selective learning. That means they would ignore knowledge and they would go only for procedures, because that is what is going to be asked for by the examiners. And then another thing actually which became apparent shortly was that experts are experts because they know more. Experts are not the ones who can perform some extraordinary skills or extraordinary procedures. Rather, experts know more. And if you have to create graduates beyond competence, expert and proficient, then the role of knowledge cannot be undermined. So what are the implications? That we need to give more emphasis to cognitive elements in our assessment plan. While in the basic sciences, pre and paraclinical areas, the importance of knows and knows how is somehow maintained. But when it comes to later clinical years, the whole focus shifted on to the procedural skills rather than on the theoretical underpinnings. So including that and including sound diagnostic reasoning in the upper levels of training is in fact a key component to maintain the quality of competency-based education. And if we look at competency as a combination of attitudes, professionalism, values, communication, and ethics, and we look at the 5 roles of Indian medical graduate, of course now there are 7, but this is a slightly old diagram. So looking at, for example, leader or communicator or lifelong learner or professional, you would realize that most of them are not measurable by objective methods. In fact, out of 5, if we consider, then 4 or even 4.5 roles we have actually left out because they are not objectively accessible. Even for clinician, even for practical skills, a lot of expert subjective judgment is required. And expert subjective judgment is not equivalent to bias. So that is another thing which we need to do a serious thinking about as to what we should be doing. We all hear this phrase, assessment drives learning. But what is interesting is that research shows that the impact of assessment on learning is often negative. And when I say negative, what does it mean? It leads to poor learning styles. It promotes grade culture. Students are only concerned with increasing their grades. And so a binge and purge kind of a mindset. Just memorize 2 days before the examination, just vomit it out on the note sheet and forget after the exams. And when you have, for practicals, these tick box exercises like OSCE or not following the students over a longitudinal period of time, then again, a sort of reductionism takes place. And let me add here that this research actually comes out from very good institutions, from Maastricht University. And so has a lot of credibility and dependability. We often talk of objectivity and talk of AI and ChatGPT and so on. And actually people are suggesting to have humanless assessments. So are humanless assessments possible? Let's look at MCQs, the prototype of objectivity. Even a highly objective method like MCQ, for example, undergoes a lot of human intervention. Blueprinting, question framing, what distractors to write, what is standard setting, and when the marks are lowered. Actually, they all depend on human judgment. We have recently seen in NEET examinations when they decided to give grace marks, and then the whole row erupted over it. When you lower the criteria because you don't have adequate number of qualified candidates to fill up the seats, then again objectivity goes for a toss. One can say that we have computer designed question papers, true. But again, that computer designing actually works on what the person programming has put into the system. So again, it is somebody's subjective interpretation. So why not use it in a much better way? Subjectivity is not bias, I said earlier. And using authentic assessments, that means assessments which represent the actual task which the students are going to perform in their later life, and I am referring to workplace-based assessments, are actually need to be promoted and implemented. Don't forget that most important things are the most difficult to measure. It's easy to measure knowledge by using MCQs. It's easy to measure clinical skills by OSCE or long case or Osler or other similar methods. But it is very difficult to measure professionalism. It's very difficult to measure ethics. Very difficult to measure lifelong learning, self-directed learning. And so what happens? You have to make a choice. Whether you want to use only standardized test or you want to use authentic measures of doctoring. A doctor has to perform many tasks which are beyond the standardized testing. And although there may be some psychometric skepticism about subjectivity and objectivity, the issue needs to be deliberated more. Validity and reliability is another important part. And when we say that we have to build validity, then having authentic assessment is in fact one of the very important interventions to bring validity into assessment, because then you relate assessment to the later task which the students are going to do when they go out in practice. Interestingly, all through our training in basic and advanced courses, we have learned that there can be no validity without reliability. But in fact, what actually happens is that there is a seesaw relationship between reliability and validity. And when I say reliability, I'm talking of reproducibility. The more you go after reproducibility, the more you discard things which are not easily measurable. And more toll it takes on validity of assessment. So you focus only on the clinical skills, but you leave out communication, you leave out ethics, you leave out professionalism, you leave out sympathy, empathy, because they are not reproducible. Each examiner might measure them differently. And role of assessor becomes important in this situation. There's a lot of research to say that expertise of assessor contributes significantly to the quality of competency-based education. Assessment literacy and expertise, again, is highly rated and highly emphasized. Somebody like Lockyer, writing on behalf of international CVME collaborators, actually says that assessor becomes the primary instrument rather than the tool that he or she uses in assessing. So it's not whether MCQ or OSCE is being used, it is how the assessor is interpreting the performance of the student. And we have all heard about this concept of utility of assessment, which actually means that you can have a meaningful trade-off between attributes of assessment. And when I say that, what it means is that utility of assessment is represented as a notional product of validity, reliability, feasibility, acceptability, and educational impact. So that means that an assessment can be low or variable on different criteria: validity, reliability, feasibility, acceptability, and educational impact, but can still be of same use, same utility. And there can be another assessment which, by virtue of its high educational impact, can be more useful than an assessment which is high in other criteria. And if the educational impact is negative, if your assessment promotes the students to do a rote learning, if it promotes the students to do a selective learning, if it promotes them to ignore certain parts because they are not going to be asked for in the examination, then actually the entire utility of assessment can become zero in spite of having a very high degree of validity, reliability, feasibility, and acceptability. So keep this in mind. The meaningful trade-off between the various concepts of assessment. And before I leave, I'd like to take you through the story of Mahabharata. We have all heard about Eklavya. He was a very skilled archer, so much that he could fill the mouth of a dog by his arrows without actually hurting the dog. But he could never become great. Why? Because he had learned only Shastra, not Shastra. He had the skills. He didn't have the knowledge. And then the second character, Duryodhana, he had Shastra. He learnt about Shastra. But still he was not considered great because he lacked professionalism. In an era where you had to invite your opponent for a battle, and only if he agreed could the battle take place, he wanted to kill the Pandavas and acquire their kingdom. And so this lack of professionalism was actually his undoing. And then you think of Arjun, who learned about Shastra from best teachers, who learned about Shastra from some of the best gurus, who was very professional in his approach to the war and battle and the contemporary circumstances. But when the time to demonstrate his competence came, he gave up. He simply gave up. And the reason for his giving up was not inadequacy in his training. Krishna never told him, okay, you go for another training, come back and fight. What he did, he addressed the attitudes, the behavioral aspect. And it can surprise us that in a discourse which happened between Krishna and Arjun, prompting Arjun to fight the war, must have lasted at least 3.5 hours, comprising about 700 shloks. And in those entire discourse, not even once the word war has been mentioned. It's all about addressing Arjun's attitudes, his approach to the whole process. That was important. And that is, I suppose, the lesson for medical educators to improve the quality of competency-based education. You have to not only train them in Shastra, but you also have to train them in Shastra. You have to inculcate professionalism. You also have to give them training in multiple contexts by multiple teachers and address their concerns. It is only then that we will be able to have a quality-based competency medical education. 5 years ago, we had proposed this model of competency-based assessment. And what it says is that it has to be criterion referenced. You cannot compare one student with the other. And that's my worry actually. When the next comes, then you are going to use it as a norm reference testing. It should be continuous, ongoing assessment. It should be based at the workplace, and it should involve expert subjective judgment. And of course, it has to be continuously mentored and provided feedback to ensure that the student actually has a continued professional development. Now, faculty development becomes crucial in this whole thing. In an earlier slide, I told you about the role of the assessor, who becomes the most important tool in competency-based assessment. And it has been rightly pointed out that the benefits accruing from assessment are actually directly proportional to assessment literacy and expertise. Generic training, I think that era of ACME, BCME probably is gone. We have trained enough people. What is required more now is to train or have a focused training on behavioral observation, frame of reference training, performance dimension training. These are the things which are going to help us improve the quality of education and quality of training. So my carry home for you is that competence is specific. It is not generic. So that means every competence has to be assessed at some point of time. Not everything will be assessed in the final exams, but at some point of time. One measure is no measure. Howsoever good, howsoever well designed, one assessment is no assessment. Objectivity is not the same as reliability. You can build in validity into your assessment. Assessment drives learning both ways. Most of it is negative, but with effort, you can actually give a positive twist to it. And no single method can do it all. You have to have multiple assessment methods. And please remember, assessor training is very important to ensure the quality of assessment. So thank you very much for being with me and giving me a patient hearing. Thank you.
So, sir, my question was, yes, we do understand that you have you have highlighted that there should be multiple types of assessment to do a 360-degree evaluation. But for doing that, we have to go for formative assessment. In summative, everything to be done is not possible. And then formative is only has only become an eligibility criteria and is not playing any role in summative. So what is your take on that, sir?
Thank you for putting that question. Am I audible? Somebody?
Yes, sir.
Am I audible? Okay. So thank you for putting out that question. You are very right that formative is taken as an eligibility criteria and is not added to the total summative score. But that is one way of looking at it. The second way of looking at it is that since formative is not added to summative, you can actually do a lot of experimentation with formative. So many things which we do not assess because they are subjective. Now you can assess. You can assess the student on communication, on professionalism, on leadership, and so many other things, which was not possible if these marks were going to be added to summative. So let's see this as a positive opportunity. And in fact, this is one of the one of the very important things which has been done to the assessment plan for competency-based curricula, that there are only formative assessments, which don't count towards final. So that provides us a more leverage, that provides us more opportunities to really assess many of the competencies which otherwise we used to give up.
Yes, sir. Thank you so much for giving a different perspective. So we have one question that, is there any specific assessor teaching method? Training method.
Yeah, there are plenty of assessor training methods. And I don't think in this short period I will be able to enumerate all those kind of things. But very recently, we have actually started a fellowship program in assessment of health professions, where we are actually imparting various kinds of training which are required for a good assessment in competency-based curricula.
So, sir, if possible, you can please put those things on the chat. What are the different methods?
Okay, I will write there.
Thank
I
you
will
so much,
write
sir.
there.
Thank you so much, sir, for being with us and enlightening us about the different methods of assessment and giving us a different perspective for the whole assessment system. So thank you, sir, for being with us and giving us the whole new perspective for looking at the assessment. We are really grateful for that. And with this, we would like to close the session. Thank you for being with us. Thank you, sir.
Thank you, ma'am, for chairing the session. I would like now request Vimla Venkatesh, ma'am, to kindly felicitate our chairperson for today.